Good evening, everyone, and welcome to weekly webinar session on expert appraisal emergency medicine. Today we have Dr. Nitin Jageshia, Regional Director, Emergency Medical Services, Apollo Hospitals, to share his valuable insights on trauma resuscitation. We welcome you, sir, to the session, and we look forward for engaging session, sir.
Thank you. So welcome everyone. I'm just going to go through trauma, which is by and large what we are mostly interested in when we want to work in emergency medicine. So hopefully I'll go through some slides and some things about how all of us should approach what the pitfalls are and things like that. To go through my topics today, I will obviously be talking about how do we approach trauma, how we prioritize various injuries and mechanisms and so on. Talk about decision making, which by and large falls on our shoulders as emergency physicians because it's a multidisciplinary injury and we need to lead various surgeons in the correct sequence of events. We'll spend a few minutes on damage control, resuscitation, and also traumatic cardiac arrest algorithm towards the end. So to get us all focused, let's imagine we're in the emergency department and we have a 38-year-old female who's been involved in a road traffic accident. As you can see, tachycardic, tachypneic, low blood pressure, but she's talking. So two things that we need to focus on. So do we need to know specific injuries? I've actually put them on the screen. She's got a hemopneumothorax, abdominal distension, few fractures and lacerations. So do we actually need to know the injuries, exact injuries, specifically what this patient has? The answer is no, as we know it with primary survey and ATLS. So how do we proceed? We talk about ATLS. First is airway, because airway kills before breathing. If there's a problem in airway, it will kill you before a problem in breathing kills you. Similarly, breathing would kill you before your circulatory issues, and so on. Airway in trauma always goes with cervical spine, what we used to call immobilization. Now it is spinal motion restriction. Breathing with ventilation. So obviously we assess breathing, but we also look at the ventilation part of it, how the saturation is doing, what the actual effort is, and what is required. Circulation with hemorrhage control. So as we know, trauma, most likely the shock is hypovolemic, and hypovolemic. So we need to make sure that we are controlling whatever hemorrhage we can, and we'll spend some time on that. Disability always goes with pupils, so looking for intracranial injury, any focal neurology, and of course sugar, the glucose, goes with disability. And then, as we know, the most important part also is environmental control. We need to expose, we need to see the patient top to bottom, front and back. So we'll have to expose them, but we have to make sure that they're not getting hypothermic. So moving on, another case. So more or less similar, tachycardic, tachypneic, quite a low blood pressure for a 45-year-old, 90/60. Saturations were 88 and they improved. And again, GCS 15 and talking. So the first thing we do is airway. So for airway, you're looking at, how do you assess the airway? Easiest thing is talk to the patient. So if the patient can talk back to you, it will give you a lot of information. It actually tells you much more than you're primarily interested in airway, whether it's patent, whether it's protective. So if they're talking to you, that means it's both patent and it's protective. If they are moaning at you, you know that it's patent, but it's probably not protected. If you get added sounds, gurgling, any kind of stridor, some kind of assessment of bruising, burns, or any facial trauma, any maxillofacial trauma, it tells you that potentially the airway is threatened and not patent. Especially if you have vomitus or you have blood, you have some gurgling sounds, your airway is not patent. And generally, if it is not patent or when it's threatened, it is probably not protected. So then we have to do both. But if you talk to the patient talks back, it tells you that it's patent, it's protected, and it also tells you that they are able to, ventilate themselves. They are actually got some circulation to the brain, and they're actually responding back to you. So talking to the patient actually gives you a lot more information when we are actually doing the airway assessment. We talked about spinal motion restriction. So the difference between immobilization is we would not allow the spine to move at all. But that now for a long time has changed to spinal motion restriction. What that essentially means is whatever procedures, treatment, when we are moving them to scan or back, moving them to operation theater, we minimize or we restrict the movement. We don't immobilize the spine, but we restrict any movement with respect to the spine. You've got a couple of pictures there. You've got A and B. Ideally, I would obviously like this to be interactive and which is the better, which is the correct immobilization. So because we can't have that interaction, it is picture A. You can have it, as you can see, the collar is taken off and one of the team members is holding the neck. So while we are going to, as you can see, intubate this patient, we do not want that to move. So the person doing the laryngoscopy, not getting a good view or to try and get a good view, they may excessively move or they may actually move the cervical spine. And the person holding on to the neck just allows the person intubating, just lets them know that you're moving it or the neck is actually moving and you can't do it. So it is more about restricting movement rather than holding it in one place. Lot of our trauma patients can be agitated. So what do we do in those cases? Again, we don't want to make the injury any worse, so we won't be rigidly holding them down or tying them because they'll actually move the rest of their body and they can cause more damage. So you would again try and minimize the movement that is possible. Why we don't fully immobilize them and we can actually allow a little bit of movement is that the mechanism, the actual trauma that happened, is going to be a lot more force that has gone through the spine compared to the movement we do, as long as we are cautious about it. So airway would always go with spinal motion restriction. Breathing would go with ventilation. Again, you've got a slide there. Hopefully the X-ray is projecting well. And I will tell you what is on it, but I'll just give it a few seconds. So hopefully you try and make out what we are trying to see here. So as you can see, it all being the soft tissue doesn't look very clean. And this is what you get with surgical emphysema. Same thing when you palpate, you will get the crepitus and you will feel that. And this basically means that there is a leak. There is a leak from within the thoracic cavity to the soft tissues. And this is also going to interfere with your ventilation. So when we are doing trauma management, breathing with ventilation, so we check the respiratory rate, we check the saturation. The previous picture, if I just go back, is you can hopefully see, you should always inspect from the foot end and you can see the left-hand side, the left side of the chest is unequal, right? So you're going to do the inspection and you're going to feel for any kind of crepitus, which could be both bony if there's rib fractures or if there's subcut emphysema. And at this moment, you're making sure that you're doing everything, which includes obviously starting 100% oxygen, 15 liters, non-rebreather mask should start with the airway itself. As soon as the person talks back to you, or even if they are moaning, oxygen starts immediately. Ventilation is more whether we need to intervene, whether we need to add anything. If they are not adequately ventilating themselves, we would have to uh, support their respirations. Another scenario, well, it's the same scenario. If you see the vitals are the same, if your airway and your breathing are intact, or they are, not a problem at the moment, you would move on to circulation. So again, you've got a picture there of a full trauma team. There are multiple people. There's somebody at the head end, probably looking. For those who have spotted the oropharyngeal or Guidel airway, it tells you that the patient is obviously obtunded, GCS probably less than 8. You can only insert the Guidel airway if the GCS is less than 8. Otherwise, they would have an intact gag and you may initiate vomiting. Similarly, there is other team members doing their various bits. So what are those? Basically, what we're doing is assessing and treating simultaneously. The whole principle of primary survey is to identify and treat any life-threatening injuries. So if you remember my first slide, when I asked the question, do we need to know the specific injuries? The answer was no, because you need to identify and treat the life-threatening conditions in the primary survey, starting from the airway to breathing, to circulation, to disability, and then to exposure. The recent change with ATLS is X. There's an X before the ABCDE. The X stands for exsanguinating hemorrhage. So trauma, by design, you would expect that there is blood loss. So if there is any exsanguinating, any heavy blood loss that you can spot when you see the patient for the first time, whether it's pre-hospital or within your department, is to stop that bleeding, whether that is with direct pressure, whether it is with other things. We will come that to in the next slide. So what do we do with a shocked patient, a hypovolemic patient in trauma? Is you'd obviously have all your monitoring on. You would have your ECG monitor. You'll have your SATs or pulse oximeter. As we know, 2 large bore IV cannula in both antecubital fossas. If you are having access to a gas machine, you may get a venous gas or an arterial gas. Depending on if you have a breathing issue, you want an arterial one, otherwise venous would suffice. Other labs that you will send off. So typically, if you don't have enough samples, ideally your first sample should be a CBC and a cross match, grouping plus cross match. And then if you have additional samples available, you can send the rest. At the same time, you'll be treating this patient like we talked about oxygen. You start 15 liters non-rebreather mask oxygen immediately. IV fluids, IV meds, which by and large at this stage would be analgesia in the form of opioids, depending on if it's a serious trauma or as simple as paracetamol. IV antibiotics. And those who are really switched on listening to this session would think about tranexamic acid, right? So if it's within 3 hours of the trauma, we're supposed to give a gram of tranexamic acid. You start monitoring them, input and output, so whatever is going in. We'll just spend a couple of minutes on the fluids. What, how much, and how. So you'd want to give balanced crystalloids. You don't want to give any colloid or starch. Blood is the best product, but we may not all have access to blood immediately. So we start with crystalloids. We start with balanced crystalloids. More and more there's evidence in critically ill and critically injured patients. Balanced crystalloids are even superior to normal saline. So whichever balanced solution is available to you, typically we would start now with 500 milliliters going in stat as a bolus. And then the important part of the fluids again is to reassess. So if you had a blood pressure or a MAP reading, before you gave the fluids versus after you gave the 500 ml bolus, and you'd see how they respond. We will talk more about blood products shortly, but about crystalloids, you would give 500 mils, reassess, BP is still hypotensive, they're still tachycardic, you'd give another 500 and then another 500. Obviously, if you're not having a response like we were taught with ATLS, you've got responders where the tachycardia comes down, the BP climbs up. You've got transient responders where the BP comes up but drops straight back down. And you have non-responders. So if you're looking more at transient and non-responders, you're already thinking about blood products. But while you don't have bloods, it's the balanced crystalloids. So let's talk about shock, which, like I mentioned earlier, the three causes of shock in trauma are hypovolemia, hypovolemia, and hypovolemia. We don't want to confuse ourselves by thinking about other causes. Certainly, you need to think about obstructive shock, but we don't want to think about any of the other types of shock at this stage. A hypotensive trauma patient is hypovolemic. They're losing blood. That is the principle of managing this stage, any kind of shock. So you're going to do your ABC like we discussed. You're going to manage your airway if required. You're going to give oxygen, breathing and ventilation. If you're required to take over mechanical ventilation, you'll go with that. And then, like I mentioned, if you've got a transient or a non-responder, you're going in for massive transfusion. Very important part of massive transfusion is what we call close the tap. What do we mean by close the tap? So we've got a tank in our body. We've got, 5 liters in most adults would have 5 liters of blood, and that is getting lost somewhere. That is being, somewhere the tap is open. And there's a concept called as a cavity triage. So which body cavity can you actually lose significant amount of blood? I haven't put in a slide on the grades of shock 1, 2, 3, 4, 15%, 30%, 45%, and more than, we've gone into lawn tennis there. 15%, 30%, 40%, and more than 40%. So what we need to know is where is that blood going? And the mnemonic is 1 on the floor and 4 more. So like we spoke earlier, exsanguinating hemorrhage is now even before airway, and that's 1 on the floor. So any obvious bleeding that you can see, and like an amputation, a partial amputation, degloving, anything that is actively losing blood, we need to control that. Then we go to the other 4, starting with the chest. So massive hemothorax. Treatment. We can all do it. It's bedside. We put in a chest drain. Most of the time you drain the blood, lung comes up, and that itself causes the tamponade. About 90% of chest injuries that reach us to the emergency department can be saved with a chest drain. They do not need thoracotomy. To complete that, as we know, thoracotomy is indicated if you've got more than 1500 ml drained blood immediately, or 200 per hour for more than 2 hours. They need to be gone to thoracic surgeons to theater. So the first cavity is the chest. Next is your long bone. Seems to be the most common, and we lose about 1.5 liters with one femur, 1 to 1.5 liters per femur. So this is where we can really make a difference. Look for it right at the start. We actually teach ATLS as A, B, C, D, E, which is a vertical approach. But actually we treat trauma as a team, which is a horizontal approach. We have 4, sometimes 5 team members. If you're lucky to have a trauma team, you'd have the orthopedic, surgical, and other colleagues with you. And when you're actually talking to the patient and assessing airway, if you've identified as a team leader that there's a shortened and deformed leg or a mid-thigh swelling, you should immediately put traction on that. Traction doesn't mean you get the Thomas plane, you get the skin traction, and start doing all that. Because obviously, if you've got it bedside, great. But actually, what it means is just pull the leg straight. God is very kind to the orthopedic surgeons, so we have one of each. So if you've broken your left leg, left femur, you just pull it to the length of the right femur. You don't need to know how much to pull and things. So as long as the medial malleolus of both feet match, you've done enough traction. So your second cavity or second place where you can lose a lot of blood causing shock is your long bones. The third one, our favorite, focus, finding fluid in the abdomen. So if you've got this, they need to go to theater. This is not something we can do bedside like the chest or the femur fracture. This is something we pick up when in shock, in trauma, and you can show free fluid. This patient needs to be going to the operation theater. The fourth one is your pelvis. Again, you can see an open book pelvis over there. You can lose anywhere up to 2.5 liters of blood in your pelvis. That's how big the cavity, the pelvic cavity actually is. Again, this is a clinical diagnosis like the femur. You may get an X-ray. If, like I said, you're in a well-developed department, you've got X-ray available. You would do only 2 X-rays in primary survey, chest and pelvis. But you can identify this with the with an externally rotated leg. Both legs will be externally rotated, and we no longer do the pelvic compression test. All you do is you can do a gentle palpation along the anterior superior iliac spine, check if there's any tenderness, obviously if the patient is alert and able to give you feedback, plus other signs of blood at the meatus, perineal bruising, uh, would suggest you a pelvic fracture. If there's a pelvic fracture, you put on a pelvic binder. You don't have a binder, you can use a bed sheet. Again, this is a hypovolemic shock. You put the binder on irrespective, because you know this is one of the 5 areas you can lose a lot of blood. And by putting the binder on, what you're actually doing is you're reducing the size of the pelvic cavity. 85% of your bleeding in the pelvis is because of your pelvic venous plexuses, which are venous. So they are low flow bleeding, which by closing the cavity, you would create a tamponade and get control of it. If you're unlucky and your patient has arterial bleeding, then obviously the binder won't work. But like I mentioned, 85% of the times the binder would be good enough for that. A binder which is lower is better if you can't get it at the right height. The right height is the level of the greater trochanter. So the center of your binder should be at the greater trochanter. Other practical tip on it is you should not be able to do a femoral stab if you've got the binder put on correctly. It will come right in the way. So coming back to cavity triage, in a hypovolemic patient, they've got loss of blood either on the floor or 4 other areas like we mentioned. Certainly, it can be retroperitoneal as well, which is difficult to diagnose because your EFAST will not pick that up. But if you've got no femur fracture, you've got no pelvic fracture, your chest X-ray doesn't show a lot of blood, there's no blood outside, and your FAST is negative, you're probably looking at retroperitoneal. So it's more, out of exclusion. But by and large, keeping this kind of picture in mind, when you've got a hypovolemic shocked trauma patient, this is your areas. The common place sometimes you may get confused is the cranial cavity. Remember, the cranial cavity cannot take so much of blood. It's a fixed rigid box, except in children. In children, you can lose a lot of blood from the scalp itself, as well as because of the fontanelles, they may be able to take a lot of blood there. Again, the volume changes. So any one of us, it's 70 milliliters per kg. So when you're a child, you can imagine how small the blood volume is. So even a small loss would easily calculate to a 15% or 30%. A slide which all of you would already have seen is a positive FAST scan. As you can see, there's tamponade around the heart, or rather a pericardial effusion causing the tamponade. You've got free fluid around the spleen, around the liver, and you've got some black stuff outside the bladder. So these are the 4 views that you need to do. These views are operator dependent, they're dynamic, and most importantly, there's nothing called a negative fast scan. A positive fast scan is you show free fluid, and then you know, okay, hypertensive patient, bleeding in the abdomen, and you have the surgeons to take them to theater. If you can't see free fluid, it may be because you've not got the right views, it may be that it's not collected enough, and so on. So you need to redo it. Once you've got a shock patient, you've started your crystalloids. Obviously, we need to talk about the massive transfusion protocol. This is just a template which I'm sharing over here. A brief word on what we mean by protocol versus a guideline. A protocol is something that happens in a specific hospital or in a specific organization which has been signed off by everyone involved. So that when that protocol is triggered, things just flow. There is no discussion. Like if you all will remember, we would call the hematologist and say, we want this, we want that. And all that would create a bit of, oh, why do you need this? Why not that? So to avoid all of that in a time critical situation, you have a transfusion protocol, which has been agreed by the blood bank, by the hematologist, by the surgeons, by the anesthetists, by the emergency physicians, by the intensivists before, and it is signed off. So as soon as anywhere in the hospital they need blood urgently, they would trigger this protocol. And automatically, depending on what has been agreed, whether it is 1:1:1 or 2:1:1, you would receive pack 1, which would include some RBCs, some platelets, and some plasma. And you would start with that. Obviously, there are a lot of things you monitor, which you can see in the ping box, and you would look after the temperature, calcium, and so on. And based on this, you would give the pack 2. Remember, this is filling the tank. There's no point filling the tank unless you're closing the tap. So this is the parallel, just like assess and treat. While you're giving this transfusion, you need to be moving the patient along for an intervention, either a surgical or an interventional radiology, something that is going to stop the bleed. Typical triggers that we know of, which have some evidence behind them, is the ABC score, where you have any 2 of these features. You can also have if you're needing more than 3 units. And the most basic is the shock index. So again, like I mentioned, it's a local protocol. So these triggers are local. They should be signed off. They should be agreed. Obviously, if you don't have that, you need to have it at least in your department in the emergency where you know that these are the things. It would be the same whether it's a trauma patient, whether it's a massive hematemesis, or whether it's an ectopic or a postpartum hemorrhage, any blood loss. Tranexamic acid, we already spoke about that. You need to give it immediately. And, as you can see, the survival and the minutes slide over there. Exposure, hypothermia. We've gone through the triad of that. Now it's diamond and so on. But bottom line is hypothermia is not good. It doesn't help. It actually pushes the downward spiral for a trauma patient very quickly. So we need to have, again, if you're not monitoring or we are not measuring this, we will not be able to identify or prevent or treat the hypothermia. So we need to have a core temperature monitor, either esophageal or rectal, so you can actually measure it and you can actually correct it. There's a role of calcium, which you saw in the massive transfusion protocol as well. You're going to measure it and you're going to replace it along with that. Now, we've spoken quite a bit about ABC. I've not gone so much into D. Technically life-threatening, we're talking mainly hemorrhage. Let's talk about a bit about decision making now. So we've gone back to the original case, 38-year-old female who's tachycardic, tachypneic, and multiple injuries. Here is what we were talking about, the triad or the diamond, but it's actually a vicious cycle. It's a separate entity called acute traumatic coagulopathy. So this is not only if you on any anticoagulants, it's not only because you've lost a lot of uh, clotting factors or you've diluted. It's actually a separate thing called acute traumatic coagulopathy, and it actually pushes this circle round and round. So you've got hemorrhage, which leads us to tissue hypoxia, hypothermia, again coagulopathy, which will lead to acidosis. Acidosis makes coagulopathy bad, and coagulopathy means you bleed more and you're hemorrhaging. So it keeps going round and round. So if we want to stop this cycle, we have to stop all three things: coagulopathy, acidosis, and hypothermia. Hypothermia, how do you stop? Obviously, you warm the patient up or don't let them get cold. Don't give them cold stuff. Small caveat, we've got balanced fluids in our department. Most of our departments are temperature controlled and they are around 24 degrees. Body temperature is 36. So you're actually giving cold fluid to the patient. Blood, as you know, comes from the fridge, even lower. So we need to find ways where we are not cooling them further. Acidosis, so obviously correcting the circulation. It's mainly metabolic, it's mainly lactate. So perfusion is an issue that will help correct the acidosis. And coagulopathy would be giving the right products. So you've got things like thromboelastography now, ROTEM, where these machines can guide you, which is the blood product or which is the clotting product that you actually need to give. We move on in this scenario where you've got a really sick trauma patient to a concept called damage control resuscitation. So as the word suggests, you need to control the damage. You're not trying to cure or reverse the damage while you're resuscitating at the same time. There used to be a period where you identify the injuries, you take the patient into operation theater. So let's look at this. It might be easier for me to explain. The classical approach was resuscitation, which is what we did, giving blood products, identifying the injuries, then they go to surgery, then they go to critical care. During the surgery, they would do whatever they can to fix everything. Whereas we now need to integrate the whole thing. What does that mean? That means that the surgical process should only be about an hour. So you just want to decontaminate. You just, like if you've got bowel injury, you just want to decontaminate. Bleeding wise, you just want to stop the bleeding. Like for example, pelvis, you would just put the X fix or you would put preperitoneal packing. You wouldn't try and fix the pelvis. You wouldn't try and plate the bones and put them all aligned and properly back together. Even when you do the laparotomy, you may choose to leave the abdomen open with a proper surgical technique and so on. But resuscitation is going on along with it. The anesthetist, the intensivist, they are constantly monitoring the ROTEM, giving the right products, monitoring the acidosis, making sure it's going in the right direction, keeping the patient as warm, keeping all the mechanisms to keep the patient warm. So all of these things happening together while the surgery is happening is damage control resuscitation. Steps. So first is the selection. Not every patient needs damage control resuscitation. It goes back to the same concept of responder, transient responder, non-responders. By and large, the non-responders are the people that will need damage control resuscitation, where you're trying to do all of this together. There is a specific role in the ED where we are trying to identify where the tap is, which tap is open. Intraoperative, like I mentioned, there is a defined period as little as possible to get control of the bleeding. This is in a very sick patient where severely acidotic, where you are just trying to get that so that they can go back to critical care, get all those things corrected, get them warmed up again, get their acidosis corrected, get their blood products in line, and then come back to theater for the definitive surgery, which may be in the next 24 hours or in the next 48 hours, depending on how quickly you can get the physiology corrected to help with the recovery. Fine. So we'll go to the last part. So we have another case. You've got a 25-year-old man. He's come off the train. There's lots of bruising all over. You've identified the legs are externally rotated. So it's an open pelvic fracture. So it's not just a pelvic fracture, it's open. And you've got an ankle fracture. You can't feel a pulse. There isn't a recordable blood pressure. There is no respiratory effort. Obviously, GCS is 3. What are you going to do? I'll just pause there again, give you a few minutes just to think, not few minutes, just a few seconds. So you've got somebody who's in cardiac arrest, for those who didn't capture that. What are you going to do? Are you going to do chest compressions? Follow our ACLS protocol, give adrenaline? Open up the chest? Do nothing? Give fluids and blood? Or all of it? So just to recap, it's a 25-year-old male. So obviously you're not expecting a heart attack or something else. So whether ACLS is applicable, I'm not sure. We've talked a lot. It's all blood, isn't it? It's all losing blood. So this man's heart is empty. The tank is empty. So by giving them adrenaline, you're not really going to make a difference. If you're compressing the chest compressions are to pump the blood around the body, but there is no blood. So what do? Nothing. So this is a protocol that I developed with the trauma unit at Southampton. So I'll just break it down. So in a trauma patient, you're obviously going to confirm the cardiac arrest, right? There is no pulse, there is no circulation. If there's a pulse and a circulation, obviously this is not applicable. What we discussed so far is applicable. You've got a pulse and blood pressure, you work on correcting that, find out where the blood is getting lost and so on. But if there isn't, in fact, you confirm a cardiac arrest, first question is this a medical cause? So it could have been somebody who had an MI while he was driving a car and he lost control of the car. They brought it to you as a trauma, but actually you feel there's a medical cause, we go to ACLS. Obviously in UK, it's known as ALS. Over here, ACLS. So if there's a medical cause likely in a traumatic cardiac arrest, you'll go with your usual protocol of AHA and you start your compressions, adre, and so on. If there's no cause, if there's no medical cause that you think, there is a question about the thoracotomy. Now, the most acceptable indications are these, where you have a penetrating trauma and the loss of vital signs are less than 10 minutes, some say 15 minutes. Or if it's a blunt trauma in front of you, they lose their circulation. The reason for doing a thoracotomy are, by and large, there are 2 or 3 reasons. First one is you're hoping, particularly it all started with the penetrating trauma, is you're hoping to pick up a tamponade. So when you open the chest and you relieve the tamponade, the heart starts beating again and all the fluid and blood that you're giving would start circulating again. The second is if you've got a massive hemorrhage from the lungs itself or from the bronchial vessels, you have some Hyla techniques. But most important is cross-clamping the aorta, putting pressure on the aorta. So whatever circulation is there from the heart is just maintained towards the heart and the brain, which are the vital organs, which is the indication of thoracotomy. So if you've got a penetrating trauma, they've lost circulation in less than 10 minutes ago, or if it's a blunt trauma and they had a circulation when they came to you, they've lost it in front of you, you would consider doing the resuscitative thoracotomy. Again, a key principle is you should be in a center where you have thoracic surgeons, because even if you do this and you get circulation back, they'll be the ones who have to actually do the definitive care. So you wouldn't be doing this, unless you have that backup. Let's say you don't have that. It's been more than 15 minutes in penetrating trauma, or it's a blunt trauma brought to you in arrest. These are the things you can do. You're obviously going to intubate you can consider doing bilateral thoracostomy. So you're kind of hedging your bets that this was bilateral tension and they are obstructed. So if you do that, you relieve the obstruction and you do the hemorrhage control like we've been discussing, put in a large access, and code red over there was massive transfusion protocol. So these are the things you can do in a traumatic cardiac arrest. Your chest compression, the adrenaline is not going to work. So you're hoping to pick up something reversible, like a bilateral tension, like an airway injury where you've intubated and corrected, or a breathing injury which you've corrected by mechanical ventilation. And of course, massive transfusion of blood where you can replace the volume. If you've done all of this and you are in asystole, you just stop. If you get ROSC, obviously you would move on to the operation theater. If you don't get, despite doing this, obviously we have the POCUS. There is something called a low flow state where you may not be able to feel the pulse, but the heart is actually beating and you can't feel the peripheral pulses or the central pulses. So at this stage in your traumatic cardiac arrest, putting your focus right on the heart and seeing if the heart is actually moving. Because if the heart is moving, obviously you can correct, give fluid, give blood, intubate, and hopefully identify where the source of bleeding and take them to theater. But if you've got no cardiac activity, so we're talking about a cardiac arrest patient, which is downtime more than 15 minutes in penetration or any number of minutes in blunt trauma. If you can't feel a pulse, you've intubated, you put your probe, you don't see any cardiac activity, you just have to stop. You're not going to reverse this by your ACLS protocol. So at this stage, we just want to summarize. When it comes to trauma, we are with X, A, B, C, D, E. Assess and treat at the same time. You're looking for life-threatening conditions. You're not looking for specific injuries. You're looking for reversible life-threatening injuries. All patients in trauma who are in shock, it's hypovolemia, hypovolemia, hypovolemia. So where do you look? 1 on the floor and 4 more. Massive transfusion protocol is your cornerstone. You should have that set up and you should be starting blood as soon as you can once you have a patient who's a transient or a non-responder. Damage control resuscitation is a very important concept that we need to know as emergency physicians so that we can guide and help the trauma team about how this needs to happen and what are the principles of it. Traumatic arrest algorithm, like I mentioned, it is not well known or well applied, but it's just something to consider because these are young patients and they're basically out of blood or they've got a massive terminal injury, which is not reversible. So our ACLS protocols may not be applicable. Not sure if we can take any questions. I'll wait for the moderator to decide, unless there's a chat box or something.
Thank you, sir. Thank you for your valuable insights. I have 2 questions, sir. What would be the recommended blood pressure targets in trauma resuscitation, sir?
So yeah, that's a very important question. We have, when we come out to blood pressure targets in trauma, we need to divide them in 2 main groups. One is with head injury and one is without head injury. That is basically what we are looking at. The gold standard 100% is the urine output. You want to see 0.5 ml per kg per hour, by and large. But when we look at blood pressure targets, if you have a head injury, you're looking at a 75 to 80 MAP or a 110 systolic. And in a non-head injury trauma patient, you're looking for a 65 MAP or a 90 systolic. This is to make sure, because the first clot is the best clot, you don't want to dislodge that. So you need to look at it whether they've got head injury or no head injury, and your targets would be different.
Okay, sir. Sir, and second question is, when can we terminate resuscitation efforts in a complex RT polytrauma cases?
That's what I just showed with my last couple of slides. If you do not, if there's no indication for a resuscitative thoracotomy, like you don't have a penetrating trauma less than 10 minutes or a blunt trauma who's arrested in front of you, and you've got the backup to do resuscitative thoracotomy, all you can do is intubate, give some fluid. If you've got blood, excellent, and see if that gets you a ROSC. No ROSC, focus, any cardiac activity, no cardiac activity, stop. You're not going to get this person back by CPR and adrenaline. If you've got cardiac activity on focus, obviously you're going to give the as much blood products and see if you get a ROSC.
That's it, sir. Thank you, sir. Thank you for your time.
Thank you.